My name is Judy Boughey, and I'm a professor of surgery at the Mayo Clinic in Rochester, Minnesota. So increasingly in the clinic, when we're seeing patients newly diagnosed with breast cancer, we are finding patients have more than one area of breast cancer within one breast. And this is because of improvements in screening imaging as well as diagnostic imaging, and then also the increased use of breast MRI in patients that are newly diagnosed with breast cancer. So the older studies of patients with multiple ipsilateral breast cancer showed that when they were treated with breast-conserving therapy, meaning lumpectomy followed by radiation therapy, these patients had a higher risk of local recurrence. And so that has led many surgeons to recommending mastectomy when patients are diagnosed with more than one focus of disease within one breast. There have been more recent retrospective institutional studies, however, that have shown a much more acceptable local recurrence rate with breast-conserving therapy for patients with multiple ipsilateral breast cancer. And that is what led to us designing the Z11102 clinical trial, looking at the rates of local recurrence in patients with multiple ipsilateral breast cancer treated with breast-conserving therapy on a prospective clinical trial. So the primary aim of the Z11102 clinical trial was to look at the local recurrence rate of patients with multiple ipsilateral breast cancer treated with breast-conserving therapy. We enrolled women aged 40 and older with 2 or 3 foci of breast cancer, where one of the foci of disease had to be biopsy-proven invasive breast cancer, and the additional sites of biopsy-proven disease could be invasive disease or DCIS. We excluded patients that had bilateral breast cancer, had a previous history of breast cancer, and those patients with a known deleterious mutation. The extent of disease in the breast had to be limited to no more than 2 quadrants of the breast, and on imaging, there had to be at least 2 centimeters of normal appearing tissue between the 2 areas that were the closest together. We designed the study as a prospective single-arm phase 2 clinical trial, and this was predominantly because of a concern of lack of patients and surgeons being willing to randomize to a study that would require randomized design between breast conservation and mastectomy. So the primary objective of this study was to look at the local recurrence rate, and we predefined an acceptable local recurrence rate of being less than 8% at 5 years. Several of the secondary objectives of this study have been previously published, and these also looked at the rate of conversion to mastectomy for persistent positive margins, and we published that to be a 7% conversion rate from breast conservation to mastectomy. We've also looked at the cosmetic outcome by patient-reported outcome at 2 years, and greater than 70% of patients have reported a good or excellent cosmetic outcome at 2 years. And then we've also looked at the adherence to the radiation fields required by the protocol and have shown excellent adherence to the radiation determined by the protocol, as well as a no negative impact on cosmesis with the addition of the lumpectomy boosts. So the protocol did require whole breast irradiation with radiation boost to each lumpectomy site. So the primary endpoint of the study showed that the local recurrence rate at 5 years was 3.1%, with confidence intervals ranging from 1.4% to 6.3%, and this was significantly below our predefined clinically acceptable threshold of 8%. We looked at factors that may be associated with local recurrence. We identified 2 potential factors that influence local recurrence. The first was in those patients with estrogen receptor positive breast cancer, we found that adherence to endocrine therapy was important. And in the 20 patients that did not receive adjuvant endocrine therapy, their local recurrence rate was significantly higher than in the 175 patients that did receive adjuvant endocrine therapy. Furthermore, we had an amendment to the protocol in 2015, which allowed the enrollment of patients that had not had a preoperative breast MRI. And this was a secondary unplanned analysis. However, in the small cohort of 15 patients that did not have a preoperative MRI, 3 of the local recurrences on the study occurred in that group, which resulted in a significantly higher local recurrence rate in patients that did not have a preoperative MRI compared to those patients that did have a preoperative MRI. And so this is really hypothesis generating information, but really opens up the discussion of the use of preoperative breast MRI in those patients that have 2 or 3 foci of breast cancer that are going on to consider breast-conserving surgery.